Hello everyone, this is Dr. Khan, Executive Plastic Surgery. Welcome to another Facebook, YouTube, TikTok, and Instagram Live. And we're also doing a recording for the podcast as well. So Kelly, you can go ahead and get started. We went through all of our social media accounts and there were a lot of questions by a lot of patients from all over. And I want to be able to go ahead and take this opportunity to go ahead and answer each one of those questions as directly as I possibly can. I want to go ahead and start off by saying that, do your homework, do your research. If you go to 10 different plastic surgeons, without a doubt, you are going to have 10 different ways of doing the surgery. Each surgeon has their own technique, their own kind of flavor, if you will, their own thought process. As you will see, there are surgeons who are exclusively using drains all the time. They're always doing a lift, even in the 25-year-old patient, because that's how they make their cuts. They're basically, technique is very different than mine. Go to the respective pages, social media accounts, YouTube, talk to the previous patients. You will get a good understanding as to what the practice is about. I get this question asked a lot. So what sets you different? Why should I come to you? And again, do your homework, do your research. You will see there's in 2025 a set of rules, if you will, that authenticate, that basically gives you the confidence that your surgeon is doing the right surgery and the mindset is correct and the technique is correct. So the first thing I want to mention is I actually created like a list over here, and I know for the Facebook live patients it's going to be not set up right, but the confidence checklist. The first thing is your surgeon should not be augmenting, and this is where the bad is so bad. The surgeon should not be putting in implants. We know so much about the breast implant illness. Not everyone gets it, but because of the rupture risk, because of the contracture, infection, acute and chronic pain, not being lifetime devices, there's small but rare association with BIALCL, BIASCC, which is the breast implant associated anaplastic large cell lymphoma, breast implant associated squamous cell cancer, because of their association with malposition, asymmetry, fluid formation around, amongst the many other problems that include self-monthly breast exam to detect for breast cancer, and not wanting to get mammograms, and now breast cancer is being missed because you have an incomplete or inconsistent physical exam or a mammogram that is not able to pick up on these masses, and now breast cancer is being missed. And overall, no surgeon who is augmenting truly then essentially believes. The whole goal here, remember, is do no harm. Remember, if 100,000 patients get breast implants in their 20s, they will eventually, within 10 years plus minus 12 years, 15 years, be needing a replacement or a removal, right? And so you do not want to do a surgery where ultimately sooner or later you're going to be running into problems. We just saw last week, I heard about another surgeon from Colorado who is not going to be augmenting because he put the pros and cons together of augmentation, and he decided that this was not ultimately going to be a healthy choice for him, for his patients. And again, with all due professionalism, he did what was the right thing, do no harm. So the first and foremost thing is your surgeon must not be augmenting. The other thing is, I want to say the whole group. So in my, there was another patient that told me within a group, for example, there is a surgeon who's promoted as only explanting because they can market that surgeon better. Whereas the surgeon within the same group, in the next room, within the same group, basically is augmenting, and they market him for augmentation. So you want to be very careful that the whole group as an entity is only explanting and not augmenting. The second thing is, as you will see, you want to get high definition pictures and videos of the chest wall. That is when the patient is on the operating room table, the surgeon gets the high definition camera video, be it an iPhone, whatever device it may be, and shows the high definition chest wall, showing complete removal of the entire implant capsule and all of that inflamed tissue completely, sincerely, because that is the ultimate proof that the entirety of that capsule and inflamed tissue was removed in the en bloc fashion, or 100% total capsulectomy. And then also high definition videos and pictures on the table cutting open of the capsule so that you can see what was removed was indeed removed, and what we see what are the internal contents within the capsular tissue. I find from a lot of patients that have reported to me, and again from the limited social media reviews that I see and do, there are many surgeons who do not post on a regular basis because those are the regular tough cases. The easy case that comes along where there's a capsular contracture above the muscle, the surgeon then takes that as an opportunity to post on social media because it was an easy case and now he can show that he does en blocs. But in reality, the many others were not done right, and he will not be able to show a high definition video or a picture. So you want to be very careful with that as well. So it should be consistently done, and this is where that 100-100-0 rule comes into effect that I say in my Facebook lives, YouTube lives. 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind. I find some of the surgeons say, well, let me go see how bad it is, how easy it is. If it's too tough, I'm not going to go ahead and do it. This is not your surgeon. The third thing is very important that your surgeon should be very much allowing on Facebook, Instagram, TikTok, YouTube, and on their social media page, a patient-to-patient discussion. So my previous patients have the transparency that what the prospective patient's going to go through. So my patients are talking to their colleagues, their friends, if you will, to the other patients, and they're basically networking and basically only getting that confidence that when they do sign up with me, they know what they're going to sign up for. So there is no second guessing about what I do. And in today's world and age, you can learn a whole lot more about a practice just because you follow someone on Facebook and social media, and you will have a good understanding as to what they're about. So if a surgeon says that my previous patients cannot talk to the prospective patients, or they cannot share the videos and the pictures of the chest wall or the operative note, then there is a big red flag. So you want to be able to have a surgeon who's going to be an advocate on social media, a surgeon who's talking about only explanting and not augmenting, a surgeon who's very proactive and very energized and enthusiastic about explanting, and is very open about doing and showing his technique to the patients so that the patients are validating him. In my case, absolutely, so that there's a check and balance on me and all those other surgeons who are doing it. Because remember, this is a surgery where the surgeon has to have the right mindset, has to be a firm believer of breast implant illness, and has to be doing it in the right fashion. And so the first thing is the belief, and then the other 50% is that he or she can carry out the operation. And that basically there is physical evidence, i.e. objective evidence via the camera, the high definition pictures and videos, that indeed the surgery was carried out in the manner as was discussed. I have seen many op reports. I have seen many, I talked to a lot of patients where the op report does not even state that the capsule was removed. And again, from a notable explant surgeon, and there was no mention that the total capsulectomy was done, which is a big red flag. Even on the consent form, the surgeon must write down the goal and purpose of the surgery is en bloc, that is complete 100% total capsulectomy without a break in the capsule, or 100% total capsulectomy, and the implants are returned to the patient. And so this, in my practice, I say there's like 5 checks, if you will. Number 1, the length of the surgery should be plus minus 4 hours. Number 2, the length of the incision should be what is approximately the diameter of the implant. So if the implant is like 600 cc's, you should expect the incision should be at least 11-12 centimeters, so as to allow for that implant to be removed safely and definitively. So the length of time of the surgery should be approximately plus minus 4 hours. The length of the incision should be approximately the diameter of the implant. Number 3, the implants are returned to the patient so as to prove that the surgery was done in the manner as was described. and the implant was not ruptured on the way out. For example, saline implant was not deflated, punctured, and then pulled out. And number 4, the capsule tissue must be sent to pathology. The dimensions, the size of the capsular tissue that's sent to pathology is the ultimate proof that this was the right volume of capsular tissue removed. So one patient that I talked to, she had a supposed end block done. This was per operative note. And then I saw the size of the capsule. It was 3 by 2 centimeters, which was a small patch, if you will. And I could tell clearly the capsule was not entirely removed. And number 5, you have on social media, the surgeon is actively talking and discussing. And, I wish I could theoretically put like a camera on every surgeon so that when they're in the OR, in the clinic, you could understand what their mentality, what their philosophy, what their psyche of the practice is, what their goal and intention of the surgery is. You have to feel very comfortable by talking to the surgeon directly, not by talking to the medical assistant. I talk to a lot of patients. They said they talk to a nurse in that surgeon's practice. They talk to a physician assistant or a medical assistant, even sometimes to a receptionist or a physician assistant or someone. Believe it or not, I talked to another plastic surgeon and he has his internal medicine doctor that he has hired to do all the talking and discussing. And I'll tell you, the internal medicine doctor is not going to be operating on you, only the plastic surgeon. So you have to talk and discuss and have that confidence by talking to the plastic surgeon. This so much so in my practice, like today I have a patient who already bought her surgery day without even talking to me. And this is the level of confidence you should have in your surgeon, so that there is the peace of mind that your surgeon is going to do exactly as was discussed. Now, please ask me questions. I'm going to go ahead and scroll through. We have Kelly who's going to basically ask questions and I'll be able to answer them. Have you ever found mold inside the implants you explanted? Yes. So remember, this is not where mold grows. Mold normally grows, if you will, like on a loaf of bread in the back of the fridge where it's damp, and it has to have the right environment. Now, having said this, within the last year, I have had 5 patients who have had mold yeast. And whenever that is picked up, I always send the patients to infectious disease so they can get the definitive workup. Whenever I remove the implant and the capsule, I take a swab in between the implant and the capsule, so the inside of the capsule. So that's a very good representative biofilm, if you will, if that is present. And so I do aerobic, anaerobic, and fungal cultures. And if the fungal culture is positive, I always send the patients off to infectious disease, like I said, so that they can get the definitive workup. 10-15% of the time, the bacterial cultures do come back positive, which is a known phenomenon. I give my patients 7 days worth of antibiotics. The first one through the IV right before incision, and then for 7 days post-op, so that there is no infection. And I'm very happy to state, of the thousands that I have done, there is only 2 questionable patients who had an infection. Again, only 2 patients who had a reportable infection, if at all. I don't think they had a frank infection because they were managed both by the general surgeons who took a swab of the skin area, and only, as you can imagine, that is going to only grow out the bacteria. So going back to the point, the mold indeed does exist, but to a very significant less extent. Remember, the 3 ways ultimately for picking up mold are: the ultimate way is the cultures. Number 2, by visualization. For me, as I go in, if I see any black matter, dark matter, or anything like that, that's kind of a red flag. Remember, you do not diagnose mold by looking at it. You have to culture it. And then the third thing is, when the pathologist looks at the capsule, if there is mold, they will see or may identify what are hyphae or branch-like structures, which are the what a fungus looks like under the microscope, and they certainly will be able to alert me if there's any findings such as that. So Kelly, please go ahead and ask me any questions.
I had an explant done 2 years ago, and I have a divot in one of my breasts. Is a fat transfer the only option to correct this?
So what can be done is, fat grafting sounds like an excellent idea. It's your own tissue, but I will tell you, in reality, it is not it's not a wise decision to do fat grafting. Number one, you can get in the area, not only at the donor side, but at the recipient side, basically pins and needles, altered sensation. Some of the fat that is injected will take very good. That's what the desired result. Some of the fat a good part of the fat, 30-50%, depending on the surgeon's technique, will get absorbed or will not deposit, will not take. And now what is going to happen is sometimes in small percentages, depending again on the technique, the amount and the quality of the fat harvested, some of the fat will form dead fat, clumps of fat, and now the patient might feel these masses, irregularities. It may form on one side and not take on the other. It may take on the upper side and not take on the lower side, and between the two breasts at different densities. And now you will be unhappy with the aesthetic result. You will be unhappy with questionable concern for breast cancer. Remember, 1 out of 8 or 9 women will get breast cancer. Even the younger population now is getting breast cancer. So screening for breast cancer by a self-monthly breast exam will be altered. Patients who have gotten mammograms, it's been reported in literature anywhere from 5, 10, 15%, depending on how much of the fat was injected. This will get picked up on a mammogram and may be a concern for potential breast cancer. Now, there are patients that have come to me in my clinic where they had fat grafting by world-renowned surgeons, breast surgeons, and now there is a concern that this mass, is it fat necrosis, dead fat from the fat grafting, or is it breast cancer, and they cannot do a biopsy of it because it's in the close proximity of the implant. And now the patient's getting serial mammograms, ultrasound, MRIs, just so that they're keeping an eye on it, and patients getting anxious. So one patient came to me and she said, there is a concern about this mass around my implant. They cannot biopsy it and it's been showing, and I'm concerned if this could be breast cancer, so I want to explant for that reason alone. And so you do not want to alter the physiology of the breast tissue. Now, fat grafting to the face, I will say excellent idea, done in a very nice, thoughtful, systematic way where there's 10-15 cc's injected. It's a permanent take. The blood supply to the face is excellent. Fat grafting to the breast is a totally different region, less relatively blood supply, a lot of inflamed tissue if you have implants, depending on the nature of the inflamed tissue that's present. And this is not ideal for many reasons. As mentioned above, you can get oil cysts, calcifications, irregularities, altered sensation, and infection, pain, like I mentioned, and not smart idea. In my practice, I call what is consistent with malpractice. If you're affecting how cancer is going to be picked up and detected and screened, and you're doing a technique that's doing harm, I call that malpractice. This is not good practice, this is malpractice. And I think it's a very appropriate term for fat grafting. So these irregularities that form, remember, this is very well established. If you look at the literature that's out there, and I'm just going to read this. We all know this. This is not like a mystery, So if you look at this, breast implant, certain labeling recommendations to improve patient communication, guidance for industry, Food Drug Administration staff, issued on October 24, 2019. You will see FDA. This is the consent list that was reported. So if you look at page 11, risks of breast implant surgery, breast pain, skin or nipple areola sensitivity changes or loss, asymmetry, impact of aging or weight change on size and shape of the breast, infection, swelling, scarring, fluid collections, hematoma, tissue death, inability to breastfeed, complications of anesthesia, chronic pain, damage to surrounding tissue such as muscle, nerves, and blood vessels, bleeding. And then on the next page, as you will see, they will mention over here, and I'm going to quote, this is at the bottom of page 15. I understand that breast augmentation may result in permanent changes to my breast tissue. If my implants are ever removed, I may be left with unsatisfactory appearance, changes to the size and shape of the breast, including but not limited to dimpling, chest wall concavity, puckering, sagging, or different incision size or location. If I am an augmentation patient, that means a non-cancer patient, any additional surgeries or medical procedures will likely be at my own expense. So this irregularity does occur. So a couple of weeks ago, I took care of a patient that had a ruptured silicone implant. There was a silicone granuloma. And when I removed that silicone granuloma, there was indeed a divot, very similar to a patient who has had a lumpectomy. Now, what the surgeon can do is bring about fatty tissue and kind of mobilize that. And you can go ahead and have, once you let like a year and a half go by, let the tissue settle and ultimately plateau off, you can certainly get what are procedures done so as to help address this, such that you essentially make the one symmetric to the other, and you're able to definitively address this deficit by moving and mobilizing tissue on the side and bringing it in. So for example, in my practice, what I do is what is a pseudo lift, where basically my assistant and I, Flamor Dekai and I, we were operating, and we basically said that we were going to go ahead and cut the excess skin at the bottom on every patient when we started off doing it initially on select patients. And what I do is I bring the tissue from the side. The patients have a fat pad on the side. I mobilize the tissue in and kind of give it a pseudo lift, if you will. There is no up and down cut. There is no cut around the nipple. There's only a horizontal cut. And when I move that tissue inward, that actually medializes, brings the breast tissue medially and towards the upper part. Now that there is no implant that's pulling the breast tissue down, and that causes that pseudo lift to address some of the lift, then most of the patients are aesthetically very happy because they did not get a formal lift. A formal lift, as you will see, is where you're cutting around the nipple, or a S lift or a J lift, and you're cutting up and down. Now you have scarring around the nipple, hypopigmented scar, that is a white scar on the nipple, hypertrophic scar, you have irregularities because of the cutting around the nipple areola, loss of sensation. Some patients are unable to breastfeed, small subset of patients who are not able to breastfeed, acute and chronic pain, again, irregularities on a self-monthly breast exam. And now when you're screening for breast cancer, you unfortunately do not have a normal exam, if you will, because you have significant scar tissue around the nipple areola up and down. And then when you do the mammogram, sometimes it does pick up on these irregularities, calcification, scar tissue. Remember, the surgeons are closing with suture up to 45 minutes, an hour, hour and a half around the nipple areola and down, because that is a lot of extensive cut. And this is where more harm is done than good. Going back to the point, as you sign up for these surgeries, it is very important to basically remove the entire implant capsule and all of that inflamed tissue below the muscle. Remove the implant capsule completely, sincerely, without touching the breast tissue. And this is where, in my practice, I am able to operate on patients, moms who are actively nursing, because the breast tissue is above the muscle, the nipple areola is above, everything is above. The implant is below the muscle, so I do not touch the breast tissue above. I do not cut around the nipple areola and down, and this is where I'm able to stay away from any potential complications of operating around. So hopefully that answers your question. We take care of a lot of patients as plastic surgeons who have had partial mastectomy, lumpectomy radiation. And there's a lot a plastic surgeon can do by mobilizing neighboring tissue and filling the deficit as you have that change in exam after having had an explant.
How long after explant until all symptoms go away, or will some symptoms not fully improve?
So this is a good question. Now, if you look from my group of patients, and remember, this is an ultimate study that needs to be done. So my patients, for example, 2 years later, ideally I should send like a questionnaire to them, and then they will go ahead and fill out how much they benefited, how much they improved, the same checklist that is out there that I have my patients fill out. I have 100% of my patients, I mandate that they fill out this list of all the problems that they have. So ideally, 2 years later, I should have each one of them fill this out, and this would be a nice study where you see the results before and you see the results after. So if you go to my Facebook page, you will see patients that I've interviewed a year and a half later. So a month and a half ago, I did a Facebook Live with one of my patients from the United Kingdom, and she said even a year and a half later, she's still improving. I just talked to a patient 6 weeks ago, and she's like, I'm 99.9% better, and this was just 6 weeks later. So anecdotally, and if you go to my Facebook page, you will see well over 90% of the patients are improved. They have benefited from the Explant. The 89-year-old patient, the 22-year-old patient, all these patients have benefited and improved. Because remember, they came in with specific complaints that they had, from a rupture to capsular contracture, pain, fluid around the implant, the symptoms of what is breast implant illness suggested, just the weight of the implant on their neck and that being gone. Now they're able to sit up straight, they're able to exercise better. So well over 90%. There is another group out of Utah that published well over 100 patients, and they said 90% of their patients benefited from the Explant. You will see over here, this is the white journal that we read. This is, look, the advertisement for Natrel. If I turn that around, and as you will see, the black box warning is here, and I'm going to read this. It says, quote, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution. Complete resolution means cure. Cure of symptoms when the implants are removed without replacement. So remember, this is a surgery where if you ask all the patients that I've operated on, did the Explant on, they almost always say two things. Number one, they wish they had never gotten an implant, and they wish they had removed them sooner because they knew they're hurting. How many patients have I talked to who said, when I asked them, what % chance do you think you're hurting from the implants? And they said 100%. And I will tell you what could be more notable than that. And what firm than that, because the patients know their body the most. Now, the one thing I want to mention is you go to another surgeon who did the 36-minute Explant on the patient that I talked to on Friday. You go to another surgeon who does a full lift, fat grafting, and a supposed Explant in 2.5 hours. How can that be humanly even achievable? There has to be a compromise in the Explant, because you can see he's doing the lift, you can see he's doing the fat grafting, right? And the bottom line here is those patients, when they recover, they have a questionable recovery. Just like several years ago, there was a patient who went to, and we have seen and heard these many patients as well. The patient went to the surgeon. The surgeon says, I'm going to do a total capsulectomy and bloc preferably. And the patient gets the surgery. This happened right here in Michigan. Now, the surgeon did the surgery and said, I did the capsule removal, and now post-op the patient's improved, but partially. And she said, I know from my heart that I did not recover fully and that this capsule was not entirely removed. Now this patient, in her heart and soul, knows that she was compromised in her Explant surgery. She goes to another surgeon who then removes the residual capsule and does an exploratory surgery, only to find out that there's capsule indeed remaining behind. And then she improves. And this is where, look at the op note. Look at the first surgeon who did the Explant is claiming that she's done, or he's done the surgery. And now you have, this patient is not improving completely. So in those many surgeons who are not completely sold on removing the capsule, who claim to have removed the capsule, these patients are not improving. And now these patients are unhappy, and they said, well, it was never the implant. Guess what? You never got the right surgery. So you cannot blame the Explant process, but ultimately you will have to blame the ultimate way the surgery was done. Now, if a patient has, my own patient has underlying severe rheumatoid arthritis, you can see the rheumatoid in her hands, you can see the severe inflammation that's present on her body. Or another patient that is wheelchair bound from MS, multiple sclerosis. when you remove the implants, she's not going to be relieved of the rheumatoid arthritis or the MS. But you will see the patient's report, the patient with MS, for example, she said, I am significantly improved. And going into her surgery, she knew she has the MS and she knew she has the symptoms suggestive of what is breast implant illness. No one, neither I nor the primary nor the patient, can conclude or understand post-op how she's going to bounce back. But she knew that she's going to get this. I knew I was going to get this out of the equation. And patients who have MS are not optimal candidates for implants, right? So that in itself alone would be a reason to removing the implant. So if a patient has scleroderma, a patient has rheumatoid arthritis, a patient has MS, those individual reasons themselves are a reason to removing the implants. And lo and behold, the patients do improve and they know deep down within. So going back to and asking and saying, is this surgery going to be worth it? Remember, in the same black box warning, they're telling you, quote, breast implants are not considered lifetime devices. The longer patients have them, the greater the chances are they will develop complications, some of which will require more surgery. So you cannot, I heard this on social media the other day. The surgeon said, well, if you don't have problems, don't worry about it, you're going to be fine. Guess what? They're telling you right here, the MRI screenings, and if I may, this is a mentor advertisement you can see at the top, but this is the fine print. MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. Silent rupture means that the patient has an unremarkable exam, normal exam, patient's exam looks good, and lo and behold, she has a ruptured implant. You would think at least there should be some pain, redness, rash. No, there is none, and that's why they say get an MRI at year 3 and then every 2 years they're onward. So they're not lifetime devices. Do you want to wait for a rupture and then do the explant? And so in my practice, I would say, and this is what is recommended, that you need to ideally replace the implants every 10 years plus minus. Now, this 70-year-old patient that I saw in my clinic, she got an explant. Do you think she should have replaced her implant so that when she's 80, she's going to have a rupture and now she has to undergo the surgery? Maybe 4 years later, she has a rupture. Maybe 30 years later, she has a rupture. The bottom line here is there's a lot of unknown, and the ultimate goal here is you're only going to benefit from the explant. In what capacity, we do not know. Now, I'm not advocating that all patients who have implants get an explant. I'm just bringing out awareness and saying and stating that if you have problems, and this is what you see, a lot of problems, you go to the doctor and the doctor says you are healthy, your labs look good, your exam looks good, your imaging is good, and the patient has all these symptoms of breast implant illness. These are the patients who are looking for answers, and this is, you will know from your heart that this is a diagnosis of exclusion. So the 35-year-old, 45, 55, 65, even the 75-year-old lady, she has the brain fog. Now someone was saying, well, guess what? You have early Alzheimer's. This patient said, I knew better, the 75-year-old lady that I operated on. The patient's complaining of joint pain, GI disturbances, dryness of the eyes, neck, back, shoulder, fibromyalgia type issues, arrhythmias. The whole cardiology workup is negative, rheumatology workup is negative, and the patient has specific complaints because she feels like she is dying and in a state of inflammation. Some more, some less, some not at all. The bottom line is, if you're experiencing these symptoms and if you're hurting, you got a capsular contracture, your implant is like hard like a rock, or there's swelling that's present, or you are not feeling well even though your doctor is saying you're healthy, it could be your implants. And this is where you need to do your research, your entire in-depth analysis, and then you will reach a sound conclusion and a decision that this is what you need to do so that you have this for a cure, complete resolution, or you have prevented the badness, or you have at least removed some of the symptoms. How many patients have I seen that have come to me that have underlying rheumatoid arthritis, underlying ankylosing spondylitis, for example, which is another rheumatological problem. And they said, even if I can improve 30%, I will be a happier patient. And this is where we're trying to do no harm and remove the element of inflammation from the patient's body. Because remember, the inflammation is basically what this is. The body reacts to implants as foreign and starts, the immune system goes on overdrive and haywire and starts ultimately hurting itself, whereas the autoimmune phenomenon, and now the patient is looking for answers. So the patients indeed do benefit. No one walks into my clinic and says, well, my implants are making me jump higher, think sharper, I have improved athletic ability. No, the moment you get implants below the muscle is cut, right, in the cosmetic patient, and the implants get in the way of upper arm, neck, back, shoulder exercises. So you have to understand, if you're thinking about implants, what they mean, what are the underlying implications of getting implants, what if you have implants, what to be looking out for, and if you're hurting, that you seek someone who's not going to dismiss you and who will understand and hear your complaints and kind of put the two and two together, that these are the implants.
How long after explant can an MRI be done to see if everything was removed?
So when the MRI cannot detect if the capsule was completely removed or not. Very important point. I'm going to say it again. So there are many patients that I have seen that had their explant done by another surgeon who was not entirely convinced technique was bad, did not believe in breast implant illness, has not done them repeatedly, and now the patients are hurting. And now the patients are saying that I'm going to get an MRI to see if I have a residual capsule or not. And I will tell you, the MRI does not pick up on the residual capsule. The MRI will pick up on a rupture. The MRI may pick up on a silicon, and certainly will pick up on a silicon granuloma, on irregularities, abnormal lymph nodes, things like that, but it will not pick up on a residual capsule. The ultimate and the only way, take home message, the ultimate and the only way that you can show and prove that your surgeon removed the entire capsule is by showing a high definition video and pictures of the chest wall showing complete removal of the capsule. I can tell you right now, I made it to the moon and back last night. I want to see a picture of that transpiring and high definition video. And not only once, but consistently from one patient to another. And then the whole firm belief, and that is the ultimate and the only way. I have seen many op reports myself, or reviewed them from patients where the surgeon stated that he did an end block and I removed residual capsule. Clearly that was present, not only by me grossly removing this off of the rib because the surgeon was not convinced or did not feel comfortable removing it off of the rib, and even the pathology reports showing residual capsule that was removed by me, and high definition videos. So if you go look at this patient that I operated on from Germany, she got her augmentation and then she was not feeling well. She sought out another explant surgeon in Europe who did the explant and a supposed capsulectomy. Did not improve. Then she sought out another surgeon who did a residual capsulectomy. Patient did not improve. Then she sought me out. So I was going to be her third capsule attempt removal. And lo and behold, I removed a lot of tissue right on top of the rib, in between the rib, on the periphery, on the side, and not only the capsular tissue, but the inflamed tissue. And lo and behold, I did the Facebook Live with her, and she certainly did improve. And this goes to showing you it's not only the implant and the capsule, but the inflamed tissue about the capsule that must be removed as well for a definitive recovery.
Is a HER scan, which is an ultrasound screening tool, is it the same thing as an MRI?
No, MRI is different. So MRI is a magnetic resonance imaging. HER scanning, you're going to see there are, unfortunately, in the capitalistic society that we live in, pan MRI, the MRI from head to toe. These are cash only, not accepted by insurance, what I call voodoo scans, bad scans, money-making scans, and I should say scams, if you will, that are fooling and tricking the patient into saying that these are nice, effective screening modalities. If they were, the president of the US would be getting it, everyone would be getting it. No, there is no true scientific validity to it. So the ultrasound is sound waves. It is better than nothing. If you look at the FDA recommendations, they want you to get at least an ultrasound at year 5 and then periodically thereafter. They tell you, the FDA, that if there's any question on the ultrasound, get an MRI. So the ultimate and definitive way, as highlighted by the mentor, is to get an MRI at year 3 without contrast, and then every 2 years thereafter, looking for what is a silent rupture. The ultrasound is better than nothing. Mammograms are there to pick up on as screening tools for breast cancer. And MRIs are the ultimate way to screen for potential rupture or any fluid, whatnot else around the implant.
Can pathology come back normal and a patient still have BII?
That's a very good question. Yes, that is correct. So there are many patients of mine where the pathologist looks at the capsular tissue and says, no cancer, good. So one of my patients said, my insurance uses Quest, and I want you to send my samples to Quest. I said, no problems. We'll have that Quest lab come by, pick it up. And their pathologist just read, no cancer, no malignancy seen, benign tissue. I talked to my pathologists at Henry Ford / Providence Park, Providence System, and I said, listen, I want you to look at and say, you have done the CD30 analysis. You have to rule out that BIALCL lymphoma. You have to rule out the breast cancer. You have to rule out any histocytic giant cell, non-polarizable material consistent with silica. You have to do a full in-depth workup of what it is and what it is not. And this is where they understand that the pathology needs to be done completely holistically as to what is PERT negative, PERT positive. And this is absolutely very true. I have had pathologists that read it, and they read it as in like quick, move on. You know, like they just wanted to finish the list. And this is how we are, unfortunately. If you have a cook who wants to cook and they just cook and they move and they're done and move on. The other person who is the real cook is the one who's tasting it, making sure, asking the person who's eating, is this good? Could I have done better? Who's put their heart and soul. So I once even reached the chairman of the pathology department and I said, this pathologist, I don't want him to read my patient's pathology slides, period. He got upset. It's like we rotate every week. I said, then we have to up the standard of how it's read because there is a check and balance. So I will tell you, each one of my pathologists who read it, and this is absolutely true. There are many patients who have symptoms of breast implant illness, and the pathology report comes back as not even inflammation noted. And remember, there is, if you will, a discrepancy between the two. And these are my own patients who weeks and months later post, if you look at the path report, says benign, no inflammation seen. And it's specifically spelled out. And you see and ask the patient clinically, how do you feel? Like, I feel like $1 million. I feel so good. I'm so glad I explanted. And this is basically where the pathology does not necessarily correlate with the patient's clinical outcome, if you will.
Can BII be something else like Hashimoto's disease?
So breast implant illness, by definition, is a constellation of signs and symptoms, not present in everyone, where the patients have complaints that are relatively vague. And as you will see, these are the symptoms that the most common being fatigue. That's number 1 on the list. Brain fog. Where young patients in their 20s, for example, they're studying for a board exam and they're forgetting what they did like 5 hours ago. They're getting in their car to go to the grocery store and it's like, why am I going? And they completely blank out, if you will. And this is the confusion that they mentioned on the mentor of the black box warning. Muscle aches, pain, weakness, joint pain, soreness, hair loss, dry skin, eyes, weight gain, weight loss, easy bruising, temperature intolerance, low libido, autoimmune problems such as Raynaud's, Graves' disease, Hashimoto's, scleroderma, multiple sclerosis, skin rashes, tingling, numbness in the arms and legs. This is the inflammation around the nerves, cold, discolored hands and feet, muscle twitching. You have nail changes, rashes, shortness of breath, heart palpitations, symptoms, diagnosis of fibromyalgia, ringing in the ears. You have headaches, dizziness, anxiety, panic attacks, mood swings, emotional instability, depression, suicidal ideation. So these are the symptoms of what is breast implant illness. Now, Hashimoto's is basically where you have an autoimmune phenomenon where the body in itself, quotes, self starts attacking the thyroid, and now the thyroid starts forming nodules, goiters, and the thyroid level gets less, so hypothyroidism, and it is the result where the thyroid function is now altered, and now the patient needs to supplement with levothyroxine or synthroid, and you can measure the autoantibodies that are present. And so now remember, this is an autoimmune phenomenon, right? Now, as I mentioned before, there are millions of people who have implants and they don't have Hashimoto's. The implants themselves did not cause Hashimoto's, and I believe that there's no direct correlation between the two. Now, having said this, they tell you right here in the black box warning, and I read this earlier, but I'll read it again for this question. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. So they're telling you it is associated with autoimmune phenomenon, right? And then they say some patients report complete resolution of symptoms where the implants are removed without replacement. So the bottom line here is that autoimmune phenomenon is now removed, gone, improvement in symptoms. Will all my patients who have Hashimoto's, will that Hashimoto's go away once they remove their implants? No. And the more research needs to be done, but there is no direct correlation in between someone getting the implants and getting Hashimoto's. Now, having said this, if you look at the MD Anderson cancer study where Dr. Clemens, the chief of plastic surgery at a major hospital of the world, looked at 100,000 patients. It's a study of studies. And they looked at 80,000 patients with silicone implants, 20,000 with saline. They concluded that those patients who had implants, and this is an objective finding, remember it's a limited study because it's a study of studies, it still has its drawbacks, but they noted that of the 100,000 they looked at, if someone had implants, they had a higher chance of getting Sjogren's, which is dryness of the eyes, scleroderma, which is a connective tissue disorder, and rheumatoid arthritis. Now, if you put the two and two together, did the implants cause rheumatoid? But what they're saying is there are higher incidence of these autoimmune. Right now, what is the true with those patients who are prone to getting rheumatoid arthritis? Now they got implants, now got it. I do not know the answer for that, and this is where more research needs to be done and more analysis of data that exists. We clearly know there is no denying the fact that patients who get implants have autoimmune phenomena that occur, and that the system is basically the implants hurt and harm the immune system of the body, and this autoimmune phenomenon is consistent and related to what is the breast implants.
How does the silicone not spill into the chest as you are removing a ruptured silicone implant?
So it's all contained by the capsular tissue and the inflamed tissue around the implant. So whenever I remove the implant, if you will, imagine there's a balloon filled with water. If the water is that silicone that is no longer the gummy bear, remember it does liquefy, as you have seen the many I would say now hundreds of Facebook lives that I have done where the implant was ruptured. Now that capsular tissue is what is keeping it contained. So you will see the many MRI reports that I've discussed that shows intracapsular rupture. So that means it's all contained in the capsule, and this is where this whole term en bloc that is applicable for cancer patients is certainly stretched to this concept here, where if the implant, if it's a water balloon, that entire shell, that capsule is removed along with the implant such that it does not fall out, and that is the whole surgery. So one has to always go in assuming, a surgeon has to assume that the implants are both ruptured, maybe might be fluid around, and that you have to remove the whole implant little by little, painstakingly, very meticulously, in a very sophisticated way. So if I may use this board, and one of my viewers like this concept. So imagine this is the whole implant, if you will, right here, and capsule sitting on the chest. The whole care and precision is that I dissect very slowly, millimeter by millimeter, all the way around the sphere, such that I'm only removing the capsule and inflamed tissue. Now, let's say, for example, there is a focal fat necrosis that I have seen. So I'll go around it whenever I feel this and it's bad. And let's say, for example, there is another tissue that is focally inflamed and it's fatty tissue. So what I'm going to do now is I'm going to go ahead in a very meticulous way, millimeter by millimeter, like I truly care. And I use the word pain. That's true. It's not fast, and you're going very slow, and you're only removing what is bad and leaving behind good precious volume, because remember, the patient needs the volume. And I'm taking my time to dissect. Remember, this is a ball. And as I'm dissecting, I always, if these are the ribs at the bottom, if you will, I can do the green one. If these are the ribs at the bottom, right here, right, I do the whole surgery in a very meticulous fashion, such that I leave that hardest part till the very end. And then I dissect all, literally millimeter by millimeter. If I find another piece that I find is questionable, I incorporate it, because I don't want to leave any bad tissue behind. So I go around all the way, very, very slowly. And remember, if this is the, do you have a red one by any chance? Yep. If this is the muscle, the breast tissue is above. I do not touch the breast tissue. I'm always below. If this is the muscle, I'm always below the muscle. And then I dissect all the way around. If you ask 1,000 surgeons who explant, the hardest part is what's on the rib. Now, as I dissect, I'm very careful, because remember, underneath here is the lung, right? You do not want to enter this. And I'm dissecting very carefully, right on top. Now I remove the layer on top of the rib, in between the rib, the muscle, that's the intercostal muscle, the fascia of the pectoralis. And I dissect all the way here. Now this part, it is super glued, but I dissect here in a very careful way, such that I remove the fascia of the intercostal muscle, fascia of the rib, which is the periosteum, the fascia of the serratus anterior, the fascia of the pectoralis minor, such that I'm able to. Now, if I completely remove it, great, that's what your end block is. Now, if I do this where now there is an inevitable break, so basically I'm going to make a small hole, there's a break here, then I basically plug this in with a sponge, a Raytech, and then I dissect here, and then I remove without any of the silicone spilling into the chest. And the fact that I do not remove the fact of the matter is, I remove all of the capsular tissue, because I remove the fascia of those respective muscles. Again, the fascia of the pectoralis minor, fascia of the serratus anterior, fascia of the intercostal muscle, the periosteum, perichondrium. And that ensures for me that there is going to be no break in the capsule. And if the end block is achieved, excellent. If 100% total capsulectomy is achieved and the plug, basically that hole is plugged, and there is no spillage of the silicone, now the drain requirement is not there. So if someone told me that the silicone spill into the chest, now you're mandated to placing a drain. If the capsule is cauterized and burned and it is not completely removed, that will trigger an immune response, some fluid formation, and now the drain becomes mandatory. If the surgeon rushes through the surgery and fast, because they have 4 cases that day, this is a surgery not about being fast, it's all about being precise. Now the drain becomes mandatory. The fact that I don't use drains in itself authenticates the fact that all the badness is removed. The blood loss is less than 5 cc's in well over 99.7% of the patients. And the patients themselves will attest to the fact that they did not need drains afterwards. And these are my thousands of patients, to the point where I even presented that drains are not required. So now all of the badness, if you will, is removed, contained, and it's done in a very thoughtful, sophisticated way, such that the en bloc or 100% total capsulectomy is done without any of the silicone spilling into the chest if it's a ruptured implant, or any of the bagness being left behind, and all of the capsular tissue is removed because the fascia of these respective muscles is removed. And now it could not be any better. It is complete. God forbid those 3 patients who had the CD30 positive in the last year and a half, those patients do not have to come back and get the residual or removal of those other inflamed tissue, because it was done right to begin with. And this is what I say: do it right, do it once, do it definitive, do it comprehensive, and whatever is removed is sent to pathology to make sure that complete total capsule removal was done and everything was checked. And that is where, as you see in the many Facebook lives that I have done, YouTube, TikTok, that is the whole essence and gist of what is explant surgery. There are many surgeons that go in and say, oh, your implants are just 8 years old, unlikely that they ruptured, and they're zipping through the surgery, and the next thing you know, silicone spills into the chest and like, oops, now I have to put a drain in, or they're not believers in removal of the capsule. So there are surgeons who I've talked to that said, and these are surgeons that I run into like at a meeting or a local hospital, for example, and I asked them, do you believe in breast implant illness? No, I'm just providing a service by removing the implant plus the capsule because the patient asked me. This is not your surgeon. One free soldier is better than 10 hired ones. One free soldier is better than 100 hired ones. And the point I'm trying to make here is it has to come from the heart and it has to be done. And this is why I mentioned in my Facebook lives from the operating room and my YouTube lives that if I were to go back, I could not have done it any better. Or 20 years from now, I cannot imagine anyone else doing the surgery any better because it's already complete, comprehensive, and detailed. In some patients, yes, I believe it may be overkill. I accept that wholeheartedly. But how do I know going into the case? Look, last week I did a patient and her implant was from 2021 and she was ruptured on the right. And I did the Facebook Live as you saw. She got the same surgery as the one patient that had her implants placed 35 years ago, and both of them were ruptured, and I went into the case knowing that both of them were going to be ruptured. And the bottom line take-home message is there's an ultra finesse and etiquette and thoughtfulness to this process. I will say this to end this question's answer. There, if you look at the board of the European Board of Plastic Surgery, Canadian board, and then the Plastic Surgery Societies here, they mention why is an en bloc? It's so exaggerated. It is risky, lengthy, and expensive. Guess what? That's what entails, and that ensures that none of the silicone spills into the chest, none of the capsules left behind. Every patient is given the thought that they have BILCL because that's how you want to approach that surgery. Another patient advocate called me up and said this one patient went to another surgeon, notable surgeon, who removed the implant and did partial capsulectomy only to and put in implants on this patient, and only to find out later on that this patient had the BILCL. Now they have to go back, remove the implant and residual capsule. Now guess what? The patient now has to go back and undergo a second procedure, and there was fluid, and now there's spilled, quote, what is BILCL lymphoma left behind matter, because there was no finesse and a thoughtful approach to her surgery, right? And so do it right, do it once. You never know what you're going to go into. Sometimes, very rarely, you're going to run into that BILCL. You may run into breast cancer. So I myself, for example, a patient had breast cancer and she had bilateral mastectomy as a result. And when I removed the right left mastectomy petals and the capsular tissue, they found within the capsular tissue breast cancer. Guess what? Her surgery was already done completely because there was nothing more to remove. The whole fascia was removed, the mastectomy scar right and left was removed, and the patient already had what was complete definitive surgery and the peace of mind that everything was removed. Next question, please.
If one implant sits more lateral and has a larger pocket on one side, do you even them out during surgery?
Yes, so very important question. So I put a dot at the nipple and I measure the distance from that on the right side down to the crease. On the left, I do the same thing from the nipple down to the crease. So on that one side where there's excess skin or it's more lateral and downward, I will pull that tissue up more, put internal sutures that medialize, pull the breast tissue towards the midline and up and I make them symmetric because I'm measuring with the ruler on the operating room table as I'm operating so that I can make them both symmetric. I may cut out more fatty tissue on the side where it is smaller, basically it's bigger, so that I can match the smaller side. So this is my time so that I can make it symmetric. There are patients that have 450 on one side and 550 on another because they had asymmetry to begin with. I will remove more of the fatty tissue on the smaller implant size so as to make that other area that's smaller to begin with match. And this is where I can do a lot without necessarily cutting around the nipple areola and up and down, because I don't want to alter her health, her physical exam when she does the self-monthly breast exam, or when she does her mammogram, altering ducts, nerves, whatnot else, whenever you cut in and around the breast tissue.
If my capsules remain behind after explant, am I still at risk for cancers?
So this is a very, very good question. There was a case report, and I'll put this up on my Facebook page again. There is a case report where a patient had an explant done and the implant was removed, the capsule was left behind. Several years later, the patient ended up getting BIALCL. And this is a case report that was published by another group, and indeed shows you that the inflammation is left behind, the body's immune system is still continuously triggered, and now that inflamed tissue that sometimes the patients complain of continued breast implant illness, those patients complain of not being the same, and certainly that is a setup for potential very, very rare what is BIALCL, and that certainly remains a risk. How many of those patients who have gotten an explant and who have had residual capsules ended up getting BIALCL, we do not know. But clearly there is that association, according to the textbook. This is very important take-home point. If there is suspicion or diagnosis of BIALCL, the textbook answer in 2025, in the year 2000, and this is well established in all textbooks and by all surgeons, if someone has a diagnosis or a concern for BIALCL, that they know that there is fluid around the implant, capsular tissue is thick and whatnot else, the textbook answer is to remove the entire implant and the entire capsule, and absolute mandate to remove that fluid and sending off for cytology, CD30 analysis, and it is absolutely mandatory to remove the whole capsule. If the capsule is left behind, the cancer is left behind, the BIALCL, and that's why if there's any capsular tissue left behind, just like that example that I gave earlier, that patient had to go back for residual capsule removal, because that way the entire cancer, the BIALCL, is then definitively removed.
How long after explant do I have to wait to have surgery again to get the remaining capsules removed that were left behind?
So I have done this as soon as 2 weeks after. So one of my patients from the Midwest, she ended up getting the implant removed, believe it or not, under local by a board certified plastic surgeon. And during that process on the left side, it was noted that, to the surgeon's surprise, that the implant was ruptured. So he goes and removes the ruptured implant and under local, washes it out. The same night, the patient has silicone extravasating out, falling out of her incision. She then goes on Wednesday, the next day, into the clinic, and then Thursday the surgeon attempts to clean it out and remove the residual capsule, but to no success. And then the patient seeks me out, and I tell the patient, get the clearance, and I did an emergent phone consult with her, and we will put you on the next available OR date, because we don't want you to heal and then to open and cut you open. And lo and behold, I removed what was the residual capsule. Now I'll tell you, any time of the day, if I have a chance of an implant that is not being operated on, be it ruptured or not, I would rather do that case than take care of someone who's already been operated on once or twice in the recent past or in the remote past. So I would rather do a complete total capsulectomy in en bloc fashion, 100% total capsulectomy, right, the first time with an implant, be it ruptured or not, than to do residual capsule, because that is definitely a more involved case. Because now the surgeon tries to remove the capsule. It's like removing pieces of wet tissue paper from the chest, and it is a much harder, more involved surgery. And clearly, if the surgeon does not feel comfortable removing an entire implant capsule to begin with, he or she will feel even more uncomfortable removing the residual capsule off of the rib if there was an attempt done previously. So the Friday I talked to a patient who had the explant done 3 years ago, and now she's going to be coming to me for residual capsule removal. And so there are patients that 19 years later I removed their capsule. So the understanding by majority of the plastic surgeons that the capsule is benign, absolutely incorrect. The understanding and belief by the majority of the plastic surgeons that the capsule will get absorbed and dissolve and is basically not harmful is absolutely incorrect, because we have a whole series of patients who have had implants removed and partial capsulectomy and did not improve, and then had to seek out a surgeon for residual capsule removal, and only then did they improve. We have not only that clinical feedback from the patient, but also from the pathology, where if you look at the pathology reports, they themselves say within the capsule was the inflamed tissue. So I have a pathology report from a patient, if you will, that I just wanted to highlight. So this is the final pathology report. This is the capsular tissue that's around the implant. It says, quote, refractile foreign material associated with multinuclear giant cell reaction compatible with reaction to foreign materials. And these are the breast implant particles. And as you will see, the pathology report read by the pathologist. And as you will see, this is Dr. Evans, who is now the chairwoman of the pathology department, who says, refractile foreign material is identified which may represent breast implant particles. There is no evidence of carcinoma or lymphoma. CD30 does not identify large atypical lymphocytes. So this tells you if the capsule is left behind, the breast implant particles will be left behind, and the trigger, the phenomenon of what is the pain, the hurt, the BII, all that will continue to be triggered, and it would be incomplete surgery. And you will see the patients themselves state this clearly, that they did not improve till the residual capsule was removed, and only then did they bounce back to a state of good health minus this foreign material, foreign body reaction, which is the breast implant particle. So it is imperative that the whole capsular tissue be removed. It's not going to be absorbed by the body. It's not like like metal. It's leaching out these particles, which is what the body is reacting to, and continued inflammation and hurt. So do it right, do it once, do it completely, do it definitively, so that when you look back at it, you have that peace of mind and confidence. Your surgeon is a believer. Your surgeon is not augmenting. Your surgeon is giving you the high definition pictures and videos of the chest wall showing complete removal of the implant capsule, that the surgeon allows for your previous patients to talk to one another, to show an excited, he's excited, she's excited about the surgery, that there is complete transparency, so the patients have excitement going into the surgery, which majority of my patients, if not all patients, have, because they know their good life, good health only awaits them, because they have gone and suffered through so much. Some patients decades of hurt from implants, some patients as early as a year, 6 months, a year and a half or two, as you will see, patients who are learning more about, they have had capsular contracture. I just found out about another patient, 28 years of age, who had breast cancer, ended up getting a tissue expander, and now has capsular contracture. She's going to go get this addressed. She will get implants, very likely. She'll get capsular contracture again, pain, asymmetry, malposition, amongst other problems, and you will see the cascade of misery starts for her. Ultimately, as you will see, the many patients will attest, as clearly seen in that black box warning, the implants are not benign devices. The longer one has them, the higher the chances are that you're going to be hurt and harmed by them, and that there is going to be a surgical resolution to this ultimately. And you know, I say to the patients, if plan A fails, plan B should not be the same as plan A. So if you get implants plan A 10 years later, plus minus, sooner or later, it's not time to repeat that, so that every 10 years or so you're living with a problem. If someone who's 22 gets silicone implants, and she at 32 plus minus will need to replace them, minus the symptoms and problems that can occur with breast implants, 42, 52, 62, 72, plus minus, some sooner, some later, maybe 20 years later, but we do not know. But one thing we know, that they're not lifetime devices. In 10 years, plus minus 15 years, they will need to be removed, and this would be the smarter, better, wiser thing to do than to replace them, if you ask me. Again, the whole goal is do no harm. I will end with this on my end. My goal of life is the same as yours and everyone else's on earth: to live to 120 without a trip to the doctor, without the misery, and without the hurt. Elective plastic surgery, and I use the word elective plastic surgery, that causes so much hurt in my mind and eyes and in my practice, where do no harm is the goal, is not worth the pain and the misery. What I'm going to do here is I'm going to go ahead and read to you, just as I wrap this up, and I kind of read this. This is, you know, the let me go ahead and choose another document that I was looking at earlier, because we have the information, we have the data, we have the information with us. This is yeah, this one. Thank you very much. So this is breast implant patient informed consent checklist and black box warnings. We can put this out so you know. This checklist and black box warning were developed by the Breast Implant Working Group, which consists of Dr. Diana Zuckerman, National Center for Health Research, Dr. Scott Glassberg, American Society of Plastic Surgeons, Dr. Ellen Matarazzo, also ASPS, James Cook, Breast Implant Victim Advocacy Group, and then the others, Breast Cancer Action. Now, the checklist has been endorsed by their organizations as a requirement to be read and signed by all potential breast implant patients. As individuals, we are also urging the FDA to include a black box warning about the risks of cancer and other serious health problems for women considering breast implants. So one of my patients from Hawaii, her daughter was considering implants, even though mom has gone through, the neighbor who got breast cancer. What are the implications behind basically getting implants, right? Black box warning: breast implants can cause a type of the cancer of the immune system, PLLC, which we talked about. People with silicone or saline implants have developed this rare disease. So saline implants, which can be deadly if not treated early. Almost all women who have developed BILCL, which is breast implant associated, meaning had the patients not had the implants, they would not have gotten it. So it's a direct cause effect. Almost all women who have developed BILCL have had textured implants or expanders at some point. Now remember, majority of the patients have textured, but remember the smooth ones are also implicated. It is underreported as very well accepted by the scientific and plastic surgery communities. Several studies also suggest that women with breast implants have a small but significant increase in their chances of developing certain autoimmune or connective tissue diseases. Women with silicone gel or saline breast implants have reported symptoms that are sometimes serious, such as joint or muscle pain. The hallmark features are this: joint or muscle pain, fibromyalgia, mental confusion, and painful skin conditions. Many of these symptoms improve partially or completely when their breast implants are removed and not replaced. So if I'm already thinking I'm running away from this, now let's go ahead and read this. I did not write this. I'm just reading it. Breast implant patient doctor checklist. So the doctor, not the PA, not the medical assistant, not the nurse, not the nurse practitioner, not the receptionist, not the office manager, but the surgeon. The purpose of this checklist is to provide information for patients considering breast implants for augmentation or reconstruction, so they can carefully weigh the risks and benefits of breast implants and make the decision that is right for them. The risks in this checklist are in addition to common surgical risks such as infection, necrosis, skin death, or problems with anesthesia. After reviewing the patient information booklet, please read and discuss the items in this checklist with your surgeon. You should not initial or sign the document and should not undergo the procedure if you do not understand each of these issues listed below. So people who have implants, this should not come as a surprise because your surgeon should have discussed this. How long do the breast implants last? I understand that breast implants are not expected to last for the rest of my life. Implants may rupture or leak at any time, and that is more likely the longer you have them. In addition, it is, now I'm going to stop here. If you look at the breast implant studies at what is the rate of rupture, you will see Mentor, Allergan, on these big companies, they study implants up to 7 years, 8 years, 10 years, and they stop. They don't go past 10 because they know the rate of ruptures goes so much, and it will be documented and evidenced as they are bad. So you will see the studies do not go up to 20 years later, 30 years later, because they know that the rate of rupture is going to be so high and it's going to self-destruct their whole company. So next quote, in addition, it is likely that I will need other surgeries related to my breast implants over the course of my life. If I am a cosmetic surgery patient, my health insurance policy may refuse to cover these surgeries. These additional surgeries and procedures can include implant removal without replacement, muscle and tissue repair, scar revisions, MRI diagnostic exams, or other procedures. I understand that undergoing multiple surgeries may increase my chances of permanent breast deformity. Patient initials. Who shouldn't get breast implants? I understand that safety of breast implants was never studied for people who have autoimmune symptoms or diseases or a family history of those diseases. Breast implants may be more likely to cause serious health problems and symptoms for these people. In addition, breast implants may not be safe for anyone with a weakened immune system or certain genetic risk factors that have not yet been identified. Believe it or not, my neighbor who got a kidney transplant ended up getting implants, and if you ask me, that's malpractice, that is unethical and wrong, and she's already on immunosuppressive medications, and the surgeon put in breast implants. A patient with cystic fibrosis, a diabetic patient who has had multiple other surgeries to the chest, if you put in implants, guess what? You have already compromised blood vessel supply to the chest area, and that will in itself cause multiple problems like wound dehiscence, skin necrosis, pain, among others. Chemicals and metals in breast implants. I understand that all breast implants contain chemicals and small amounts of heavy metals that may cause health problems. I understand that most of these chemicals are confined to the shell of the implant or stay inside the shell. However, small quantities have been found to diffuse, gel bleed from or through the implant shell, even if the implant is intact and not ruptured. Now, I'll tell you, I'm just getting scared reading this, but it is reality, and they want you to patient initials. Rupture and leakage. I understand that the longer my breast implants are in place, the more likely they are to rupture, especially after the first few years. When a saline implant ruptures, it usually deflates quickly. When a silicone gel implant ruptures, I may not notice any changes, and the rupture may not be detected by my doctor or by my mammogram, MRI, or sonogram. I understand that an MRI is recommended for silicone gel implants 3 years following surgery and every 2 years after that to check for silent rupture, and that these MRIs often are not covered by health insurance. I understand that silicone may migrate from the implant into nearby tissues such as the chest wall, lymph nodes, upper abdominal wall, and into organs such as the liver or lungs where it cannot be removed. What a shame. Since migrated silicone can cause health problems, it is currently recommended that any ruptured silicone implant should be removed as soon as possible. So I talked to a patient, and she said, I went to a local plastic surgeon, board certified, who said, well, if you're not having pain, and this was an incidental finding on a CT scan that they did of the abdomen pelvis, and you have no complaints or concerns, it's okay for you to live with a ruptured implant. Absolute no-no. And so it is not healthy to live with a ruptured implant. Do you want to wait for it to rupture and then remove it? I will tell you, take care of a smaller fire than a bigger fire. So this is the take-home message. If it's the 10-year mark plus minus. So this is another patient I took care of almost 9 months ago. She came to me from the Ann Arbor area, and I asked her, she had 0 complaints of breast implant illness. And I asked her, why are you doing this explant? and she said, my 10-year mark is up. I heard there's a 10-year kind of expiration, and I want to just remove them. I'm old and wise, and I just don't want something foreign. And lo and behold, her right breast implant was ruptured, to my total surprise and to the patient's total surprise as well. So let me go ahead and continue to read here. I understand that silicone may migrate from the implant into nearby tissues such as the chest wall, lymph nodes, upper abdominal wall, and into organs such as the liver or lungs where it cannot be removed. Since migrated silicone can cause health problems, it is currently recommended that any ruptured silicone implant should be removed as soon as possible. I understand that if needed, treatment of these conditions may be at my own expense and not covered by the insurance or a manufacturer warranty. Patient initials. BIALCL. I understand that there's a smaller risk for me to develop BIALCL, a cancer of the immune system. BIALCL is a type of lymphoma that develops on or around the scar capsule that surrounds the breast implant. I understand that the symptoms of BIALCL include breast swelling, lumps, pain, and asymmetry that develop after surgical incisions are completely healed, usually years after implant surgery. There you go. Treatment of BIALCL includes removal of the implant and scar capsule, and if not treated early, may include chemotherapy and radiation. This diagnosis and treatment may be at my own expense and is not always covered by insurance. Patient initials. Again, I did not write this. This is by a group of plastic surgeons, by the board, by the higher authorities. Symptoms of breast implant illness. Now look, what a shame. Many surgeons don't want to even utter the word breast implant illness. Many surgeons say breast implant illness is a myth. Wow, that is incredible, where there is clear documentation by the manufacturers, by the FDA, and by this group of plastic surgeons that there's no ICD-10 code for this. Why? Because there is looking the other way, not listening to the patients. Symptoms of breast implant illness. I understand that because of the lack of long-term safety data, we are still learning about the health problems that result from breast implants. Are you serious? We know so much, we should stop it right now because it's not worth the pain and misery. Quote, to date, thousands of women have reported to the FDA or to researchers that they have experienced serious health problems that several studies have linked to their breast implants. This may occur either immediately after getting implants or years later. These often include symptoms such as joint and muscle pain, weakness, memory, concentration problems, chronic pain, depression, fatigue, chronic flu-like symptoms, migraines or rashes, and skin problems. Several studies of women with breast implants have shown that they are significantly more likely to be diagnosed with one or more of the following diseases compared to the other women: chronic fatigue syndrome, multiple sclerosis, rheumatoid arthritis, Sjogren's syndrome, systemic sclerosis, or scleroderma. Look, we already covered that earlier, right? All the women who develop these symptoms or diseases can't be certain that they were caused by the breast implant. Several studies indicate that most symptoms improve partially or completely after having their implants and capsules removed. Patient initials. Capsular contracture. I understand that one of the most common complications of breast implants is when the scar tissue capsule that forms around the implant hardens. In some cases, this can be quite painful, distort the shape of the breast, and can make mammography more painful and less accurate. Removing the implant and capsule without replacing the implant is the only recommended way to guarantee that this problem is corrected. Again, removing the implant and capsule has to be removed without replacing the implant. That means removal only is the only recommended way to guarantee this problem is corrected. How many times the patient gets implants that get a capsular contracture, the surgeon does a capsulotomy, which means breaking open the capsule, but the implant is reinserted, a new one, and now your plan B is the same as plan A, which is a setup for failure. Breast cancer. I understand that all breast implants can interfere with mammography and breast exams, possibly delaying the diagnosis of breast cancer. This sentence alone should be a reason to ban implants. I hear so many surgeons going on TikTok and YouTube and Facebook and saying they're the safest thing on earth. Guess what? This line versus them, and I'll tell you, this trumps all of those surgeons who are interested in putting in implants in patients. I asked the surgeon, would you put this in your wife? And the answer was, quote, hell no. close quote. And I will tell you this is consistent with what we are seeing here. I understand that if I get breast implants, I should inform the mammography technologist about the implants and ask for additional views to improve the accuracy. How many times does that happen? I talked to a patient yesterday, and she said she does not believe in mammograms because she gets hurt every time she gets them. I understand that mammography can also cause the breast implant to rupture or leak. Wow. So here you're telling them that the standard of care is to get a mammogram, but it may cause a rupture or a leak. Patient initials. Interference with breastfeeding. I understand that breast implants and breast surgery may interfere with my ability to successfully breastfeed. No long-term research has been conducted to determine the possible transmission of chemicals and heavy metals in the breast milk of women with implants. Patient initials. Loss of sensation to the breast and nipples. I understand that breast implants and breast surgery may cause the nipple or breast to be painful or to have decreased sensation. These changes may be temporary or permanent and may affect sexual response or the ability to nurse a baby. Patient initials. And then cosmetic complications, asymmetry, implant displacement, ptosis, which is the drooping of the breast. I understand that if my breasts had slightly different shapes before surgery, then that they may remain slightly different after surgery. I understand that the implants may cause the breast to look slightly different in size or shape. I understand that the implant may move from the original placement location and that may result in asymmetry or other cosmetic problems. Breast implants can cause the breast to sag over time due to the weight of the implants. I understand that if I am not happy with the results, I may need future surgeries to improve the appearance of my breast. Patient initials. Confirmation of discussion of risk. I acknowledge that I have received and read the breast implant patient information booklet and this checklist. I have had time to discuss the information in both with my doctor, and I understand the benefits and risk of the implant and surgery. Patient signature. Physician, I acknowledge that I have discussed the benefits and risks of implants as described in the breast implant patient information booklet and this checklist. I have encouraged the patient to ask questions and answered all questions accurately. And I'll tell you, the word accurate is a very interesting word because the information that vast majority of the patients have gotten, and these are the patient's own words, are not consistent with what is accurate informed consent. So that majority of the patients, at least that come to me in my practice, and certainly out there, we can certainly do a poll. How many of them were informed of this checklist? I did not write this. I did not prepare this. And this is why, as you will see, the implants were banned initially, and that over a matter of time will and history will only inevitably repeat itself. And hopefully this time, not only with the ban on silicone, but on saline as well. The pain is not worth the pain and the misery that the patients go through. Do no harm. That's the oath. That's the goal, and that is the plan. This is Dr. Khan, Executive Plastic Surgeon.